All righty. Good morning, Pagosa. It's Friday, TGIF and all that. And we're going to get to our show with the Pagosa Springs Medical Center. And we're actually over at the hospital today, visiting with Dr. Andrew Buck, oncologist, hematologist, and cancer center medical director, and also Dr. Roy Tinguely, the general surgeon here and trauma medical director. Good morning.
Good morning.
How are you guys?
Fine. Doing good.
Excellent. Well, it's nice to be here at the hospital for this, and you guys have both been on the radio before, but maybe there's some new listeners, and would you mind introducing yourselves and tell us about yourselves a little bit?
Sure.
Dr. Roy?
Yeah, good morning.
Hi.
My name is Roy Tinguely, and I moved here in 2017 from Iowa. General surgery. We do a lot of bread and butter surgery, as we like to call it, hernias, gallbladders, and colonoscopies, which is our talk for today. I moved out with my wife, Debbie, and we have since acquired a German short-haired pointer named Trudy.
Nice. Dr. Andrew Buck?
Yeah, hi, I'm Andrew Buck. I'm the hematologist oncologist here at Pagosa Springs Medical Center. I've been in the Four Corners for just about 4 years now, and happy to be here.
Yeah, glad you guys are here. That's for sure. We love our hospital. And I take it you guys are a team. You're probably in different departments.
Yeah.
But these things that you're talking about are part of the whole process.
Yeah, so Roy, being our surgeon here, so he is a big help in doing the screening colonoscopies for the population as well as for those who have symptoms. And in the event that anything that appears malignant or cancer-like comes up, this is where I get involved, and there's a referral sent to me and my team to then assist in their care however we can.
So you mentioned colonoscopies.
Yes.
You've got a brochure right here in front of me too. Well, that's actually a different brochure, but it's the same idea, or maybe it's a preliminary thing.
Correct. Screening colonoscopies are something most people don't want to talk about. However, it's one of those necessary evils. With all screening tests, and I would say that women, start younger with paps and pelvics and mammograms. And when we get a little bit older, we start talking about the colon and colonoscopies. Men, we pretty much start talking at 45 nowadays for colonoscopies and prostate screening. And with March is Colon Cancer Awareness Month. We're talking here at the end of February about colon cancer. We know that colon cancer is one of the top 3 common cancers, and we do see a lot of it here, even at the hospital. There isn't a lot of easy ways to screen for colon cancer, and colon cancer really does not have a lot of symptoms. So it is something we have to go look for, and the colonoscopy is the best test we have right now. So we're going to talk a lot about colonoscopies this morning, but that's kind of the basic idea of why we need to do it. And everybody wants to know is, can we do something easier? And sure, things have really changed over the last 20 years. For most of the listeners out there are probably older, but all we had in the good old days was colonoscopies, and a lot of times you didn't get sedated. So it was not a pleasant procedure. And the preps back then, we pretty much had one, and it was the gallon, big old gallon that you chugged down. It worked, but it was no fun. So
and then the fasting too, right? And
and
all that. I don't know.
Yep. And I've heard a lot of horror stories over the years.
I'm sure.
And the sedation is so much better for the procedure. And a lot of people say sedation. We got nothing back in the 70s and 80s, and that's true too. So things have gotten better and easier, and the scope itself is probably the easiest part of it nowadays. Other things that people want to know about is this Cologuard. Can we do it at home? Can we send it in? And the answer is yes. And that's getting better and better, and it's being paid for by insurances. The downside to it is it doesn't really pick up polyps as well as it does cancers. and you have to do it more frequently, and you have to do it. I mean, that's the number one thing, is doing something rather than nothing, because if you wait too long, then you see Dr. Buck.
Yeah.
So,
Well, that Cologuard, you see ads about it and all that, and I mean, it's not exactly that pleasant either. But we can't go into that part.
Yeah, I think that the testing is getting better and better, and I feel sorry for the postal service,
analysts.
the postal service that has to
right.
deliver it.
Exactly.
But
I know what this is.
That's right. And I would say a lot of the positive tests, we still come in and do a colonoscopy. A lot of times we still find nothing. So it's not the best test in the world, but it is a new test, and it's probably going to get better and better. The other thing people probably hear about is the FIT test, and that is looking for blood in the stools. And it's a lot better than the old-fashioned, what we call hemoccult testing. So a lot of insurance companies are paying for these FIT tests, and they often will just mail them out to the patients. That's a good test looking for blood, and if it's positive, it gets you in to have a colonoscopy. That's the test. If you have positive testing, you need to have a colonoscopy. The FIT tests need to be done every year, and so that's something that you and your primary care doctor should be talking about is, should I be getting, my stools tested yearly? And the answer is yes. And then should I be doing the Cologuard? And the answer is maybe. And should I be getting a colonoscopy? And that also is a probably. So.
And again, so for the listeners, you said a FIT test is annually.
Yes.
So FIT is different than Cologuard. FIT is...
Yeah, FIT test just stands for fecal immunochemical test, and it's testing it for blood.
Okay.
And a lot of people used to know about the hemoccult testing that your doctor would just do in the office, but those tests really never proved to be that great. So the FIT testing is looking for blood. If that's positive, you get sent for a colonoscopy. The Cologuard is only for average risk, and we can talk a little bit more about average risk versus high risk. And that test is also pretty good. I did that myself when I turned 50. And, it makes you feel good if you have a negative test. But if you have a positive test, then you need to have a colonoscopy. And then if you do the colonoscopy and you aren't doing these other tests, then that's a 1 every 10 years if it's normal. So, and it's the best test we have on for everyone to be doing right now, because it's a camera. So we look around the entire colon and we look for polyps and we can see them. All the other tests are just looking for cells to get you over to have a colonoscopy to look for polyps or
and you can
tumors.
Do something about the polyps at that time too, some of them, maybe?
Correct, yeah. So, the real small ones we just can remove with a biopsy forceps, and if they're, medium, then we use our little snares and get them out. And yeah, so it's a one-stop shop, I always say. You come in, we can get pictures, we look for other things. Obviously we're looking for any inflammation. We see diverticulosis all the time, or most of the time. And we can take pictures, we can do biopsies, we can remove polyps, all during the procedure while you're sedated and sleeping comfortably.
So let's take a step back. We're talking about colorectal cancer today, and there's the screening colonoscopies, which are indicated in the general population, versus other symptoms that can bring on the need to then do a colonoscopy. So how about as an introduction, we can chat about some of the symptoms that would be concerning for colorectal cancer, which is different than the indications for screening. So, for example, some of the symptoms that can but don't necessarily indicate that there is colon cancer in a patient is, in general terms, a change in bowel habits, such as diarrhea, constipation, or more frequent bowel movements. Now, this isn't just like once or twice, or you have a GI bug or some sort of viral infection or some bad food that you had that caused this, but this is more so when the pattern is consistent and unrelenting, and you realize, okay, this is ongoing. So let's not get ahead of ourselves if for 1 to maybe 3 days and then gone, these symptoms came and went, as opposed to persistent symptoms. And then immediately come to your primary care provider and talk about these new symptoms. Other symptoms that can happen is a dark maroon or bright red blood in the stool. Not all colon cancers bleed, and not everything in the gut that bleeds is colon cancer. There are other things that can bleed in the gut that absolutely are not cancer. Other symptoms, back to stool comments, is narrow stools, or what's called pencil stools. When your stool size usually much smaller, but they're very narrow and long as opposed to a normal size stool. Other symptoms that could indicate colorectal cancer is a feeling that your bowel doesn't empty completely, which can also, symptoms similar to that could be something called tenesmus, or this ongoing sensation of needing to defecate so frequently. A real generic finding can be abdominal pain. And this, again, this is not a one-time came and went phase, but this is ongoing and doesn't make any sense typically for more than just a few days and then resolved. Also, unexplained weight loss, weakness or fatigue, and in general, anything that sounds like or is concerning for a pattern of obstruction, meaning something that is preventing you from having regular bowel movements. So these are things that if you have these symptoms and you discuss this with your primary care provider, please immediately make an appointment and try to discuss this with them. If there's not an appointment with your primary care provider available, there's a walk-in clinic, there's urgent cares, there's things like this you can go into to try to get more timely care for some of the symptoms you may be having. Now, so that's symptom-wise, but even without symptoms, there's indications for screening for the general population. And so there's many different guidelines or many different bodies of authoritative medical teams. In 2018, the American Cancer Society changed its recommendation for screening to 45 years old due to a rising incidence of colon cancer among younger Americans. And then a few years later, in 2021, the U.S. Preventive Service Task Force also issued a recommendation confirming the prior that colorectal cancer screening for people at average risk should start at 5 years sooner at 45, because previously it was indicated at 50 years old. So let's give also one exception to that. So let's say if you have a primary relative, meaning your mother, your father, a sibling, secondary relatives would be like grandparents, which the question is there some sort of hereditary factor here? If you have a primary relative that definitely had colon or rectal or sigmoid cancer of some form, we can move those screening parameters to 10 years, sometimes just 5 years, but 10 years before the age of onset of the diagnosis. So, for example, let's say a primary relative was diagnosed with colon cancer at 50. Well, you should probably have your first at 40. And vice versa for any other ages. So getting more specifically, so in colon cancer, on the topic itself, it is the third most common cancer. American Cancer Society's 2024 statistics showed that it is now the leading cause of cancer death in men under 50 and the second leading cause of death in women under 50.
So that's why the lower ages
Yep.
for starting these.
Well, it's also because the types of cancers between men and women is not percentage-wise the same between the sexes, as well as death rates, comorbidities, and other factors that go into our health is not the same between men versus women.
You mentioned sigmoid cancer. I don't know what that is.
So that's just clarifying different parts of our colon, right? So, for example, for the point when we swallow, first part of your GI anatomy, I would assume then we refer to as then the esophagus, and that's from just past where you swallow down to the stomach. From there it's the stomach. From there it's the small intestine, and that's the small intestine is broken up into the duodenum, jejunum, and ileum, and then that transitions in the cecal area to the large intestine. That's where your appendix is. Ascending colon, transverse colon, descending colon, sigmoid, rectum, anus, done.
Okay. Uh-huh.
So in my world of oncology, we tend to divide these up, and that's also because the treatment for colon cancer is similar but different to the treatment of rectal cancer. There is usually a radiation component in rectal cancer. And again, the treatment options for anal cancer is, again, a similar but different protocol. So, and then just to break up some misconceptions in the general community, there are some patients or people in the community I'll talk to from time to time that believe that chemotherapy is a one-size-fits-all. But the truth is the treatment options for each individual cancer often have completely different chemotherapy doses and even drugs themselves. So, for example, the kinds of chemotherapy we would use to treat breast cancer versus colon cancer versus lung cancer versus you name it, the drugs are very different from each other. The frequency, the duration, or the combination of the drugs is extremely different. So just to clarify a misnomer in the community that there is not a one-size-fits-all of one kind of chemo to treat all kinds of cancers. So they're very unique and different.
Fascinating. Okay. Dr. Andrew Buck and Dr. Roy Tinguely are here. Actually, I'm here. And they're here as well. We're at the hospital. So we're going to take a quick break, and then we'll get right back to our closing comments here. And so stay tuned. Thanks to our sponsors. We are back. So we've talked about colorectal cancer, the third most common cancer, colon cancer, and I don't think we got to lifestyle changes. Maybe did you want to talk about that a little bit?
Yeah, to talk about that.
Okay.
So there's a lot to be said in preventative medicine, and there's a lot of variables. So let's start with the basic things that we do understand. So lifestyle changes that can help prevent colon cancer would include stop smoking, limit your alcohol intake, eat a healthy diet, exercise regularly, and maintain a healthy weight. So let's talk about each of those in small doses here. So stop smoking. So tobacco is associated with roughly 1 in 3 diagnoses in all categories of medicine. So omitting tobacco abuse in any population in the world, you would expect to see a dramatic improvement in mortality, longevity, decreased comorbidities or other conditions or medical disorders. Limiting alcohol intake, another one. The data is overwhelmingly simple in that basically any amount of alcohol is associated with a higher incidence of cancer. There's not like these quantifiable if X number of drinks or X number of certain types of drinks. The studies have been more so a simple yes or a simple no. So if we take these two extremes, omitting all alcohol is your closest or best bet of omitting further risks to your health. Whether we can swallow that or not is a different question.
Right.
Eating a healthy diet. This is a very big topic for at least for quite a long time. The last decade, especially the last 2 decades, there's ongoing discussions about what diet, what kinds of diet, and how do you make your diet customized to your own person. There's a lot of debates about this being based on blood type or being based on other factors. I don't know that we've completely figured this out, but if we start with the fundamental basics of, let's say, plenty of vegetables, plenty of fruit, quality, simple, homemade food. One of the parameters I give to patients is if it's from a box or from a bag, and sometimes even if it's frozen, let's say you omit that, and then what's left over? Homemade meals. If it's fresh off the farm, so to speak, if this is something you cook and prepare yourself, you're, I think, far closer to a more balanced diet, meaning that we omit processed foods and frozen meals, etc., and go to more of an old school, simpler way of eating. Exercise regularly. There's plenty of data that supports this for so many other reasons, as well as mental health, decreasing risks for dementia, salinity, etc., and maintaining a healthy weight. Dr. Tinguely, you have any input on this?
No, I agree with all those things.
Okay.
What are healthy weights? I mean, roughly, how do you judge? I guess different age, different weights.
So number one, starting with
and height,
the
obviously height.
Of, let's just say, avoiding obesity,
right?
As a starting point, right? If you are needing to buy new clothes because you are growing. There are lifestyle changes to try to, if we grow taller in our youth, that's one thing. But if we're growing laterally, this is something else, right? So making lifestyle changes. So when you're eating more healthy, regular physical activity, and it's just the idea of trying to stay more trim. We're not I will joke with my patients and say, when we're talking about exercise, we're not talking about an Arnold Schwarzenegger kind of a regimen here. This can be daily walks, carrying some weights with you, just regular physical activity, as opposed to a more sedentary pattern of lifestyle. So, for example, when you go to that convenience store, you park at the furthest corner of the parking lot,
right,
instead of the closest one in the front. And you intentionally carry your bags a bit further. Why? Because we could all use a little bit of extra activity. I know I do.
Interesting. Well, and around here we have lots of options and great choices for getting outside and enjoying the outdoors while taking care of our exercise regimen.
And so then the other way to quantify this over time is to bring this up with your primary care provider, right? So as an oncologist, one of the core concepts that we need all of our patients to have in place is a primary care provider, a dedicated provider that the patient has an ongoing relationship with, even if they only see them once a year, just their go-to person. And to get back to the question of weight and lifestyle, this is a very large topic. It becomes a whole subspecialty for a lot of docs in medicine to just talk about preventative medicine and all of the proactive things we can do to prevent or avoid things in our lives. Because there's also sometimes hereditary factors that is more so built into your genetic makeup, and figuring out those advantages versus flaws and how to use them to your advantage.
Very good. Well, we started out talking about a team, and Dr. Tinguely and Dr. Buck are a team here at the Pagosa Springs Medical Center, and I know I hear a lot about integrated healthcare. So do you want to finish with something about that, how you guys work together? It's not just, there's several, more than just you guys. It's a big team, actually, and it's grown significantly over the years.
Just since I've been here.
2017.
Yeah, I think that this population has grown, as we've all seen, especially through COVID. More and more people in town. Our clinic has grown. But you really do need to have a primary care doctor, and I think that not only for colon cancer, which we're talking about today, but for everything. I mean, what's more common is probably your blood pressure problem, your diabetes, just healthy weights, everything that starts in the clinic, and then we kind of work our way into not so fun things: prostate, breast cancers, colon cancers, all of those testing that is actually getting so much better and easier. And, we're just talking about 1 in 20 people are probably going to get colon cancer, 100,000 cases at least a year. And maybe it's trending a little bit younger. Of course, it all comes down to what's insurance companies paying for, what's Medicare paying for, what are we doing for screening on all these different diseases. I think that doing something is better than doing nothing. And I think that's what our primary care doctors are, gently trying to convince people to do something. And, we're pushing colonoscopies because we know that's the best test, and we know that sedation is better, and we know that the preps are getting better. But a lot of people still, maybe half of the county is still not doing their colonoscopy screening. So doing these other tests, the Cologuards, the FIT test, just coming in to see your doctor and talking about your complaints, your belly complaints, your bowels, all the stuff that we love to hear about every day, will lead to it, because we when we get involved, it's usually not an early cancer, and I think then we're kind of not behind the 8 ball, because there's so many better treatments nowadays than 20 years ago, but people come in thinking, I've been so healthy and I'm 85, and I haven't seen a doctor, and so I'm healthy, and that doesn't necessarily mean you're healthy because you haven't seen a doctor. And we're all going to get something, so we have to start looking a little bit earlier than in our 80s to see if we can find, any of the other diseases that are going to,
My grandfather always said, we all have a fatal disease of some sort.
Yeah. And so the tests are getting better and better. And a lot of people come in and they've, scoured the internet and they've seen a study out of Zimbabwe. And there's a lot of studies out there and you can find a lot of information. But doing something is what's important. And if it's as simple as getting your stools checked for blood, that's a good start. If we want to do the Cologuard, that's a good start. If you want to come spend an hour with us and have a colonoscopy, that's a great start too. So,
and it is about lifestyle.
Yeah.
Not just about, living longer or whatever. It's about enjoying those years too.
Sure.
Yeah. So the other thing is, we're all, as individuals and even as a healthcare system, we're all in the hopefully recovery phase after COVID. And there's been a lot of people that have kind of disappeared from the healthcare scene, and they're very much overdue to establish or reestablish with a primary care provider. We've seen a lot of patients in the community that they've moved here to the area in the Four Corners, and they're maintaining ties with their primary care provider from whichever state or somewhere not locally, and they're yet to establish with a primary care provider here. So for those of you that are listening, I'd like to just encourage you to reach out. There's a walk-in clinic here for same-day walk-ins.
Oh, they're great.
You can always just make a call and say, hey, my name is, I'd like to make an appointment with whomever, your next available primary care provider, whether it's a physician or mid-level, et cetera, and just get back on the ship, so to speak. And so on the topic of colon cancer and screenings, a lot of people, they get very intimidated. Like, they will say to themselves, there's no way I would ever want to have a colonoscopy. Why would I ever want to do that? So let me try to encourage you, probably the strongest reason. So oncology is often referred to as the field of oncology is referred to in different ways, but it's also referred to as the equalizer, meaning nobody is omitted from the likelihood of developing some kind of cancer. Wealthy, poor, middle class, any age, any ethnicity, we are all subject to the likelihood of a diagnosis. But early screening is our best chance of cure. So, for example, the difference of a late diagnosis of colon cancer versus an early diagnosis of colon cancer, an early polyp, if detected early and is appropriately then removed, you can catch what could become colon cancer one day, which is initially in the form of just an abnormal polyp. And when you catch that early enough, you can potentially prevent this from ever becoming true invasive colon cancer. And even if something is colon cancer, let's say it's an early stage 1, oftentimes surgery and surgery alone is curative. And then you actually don't have to always be referred to an oncologist because you don't necessarily need chemotherapy. So again, while a colonoscopy may be very daunting for some people, the responsible thing is to do it, make sure we don't have any abnormal findings, because even if we do and we catch it early enough, you'll be potentially spared from chemotherapy, and surgery or even just a wide excision or even a simple biopsy of the polyp can be a curative solution to these problems.
Yeah, let me just add one thing I hear all the time. People have had a colonoscopy 10, 15, 20 years ago, and I said, was it normal? Yeah. And then they say they've removed a few polyps. And it's like, then it wasn't normal. And I think a lot of people think all polyps are benign, and they are benign, but they're also pre-malignant. Mm-hmm. If you leave them alone, and we think 10 years is about the time that it takes to progress from a benign polyp to a cancer, and that's why you always hear that you need to be scoped again in 10 years. But all polyps, with a few exceptions, are pre-malignant. And if you ever had a polyp 10, 15, 20 years ago, you need another colonoscopy, because your chance of having more polyps is high. And so I think a lot of people are, it's nice to know that you didn't have a cancer, but if you've had polyps in the past, you need to come back and get another colonoscopy. And I think that's a mistake a lot of people hear. The other thing is a lot of people also have a polyp and think they need to be scoped in 1 year, and that's usually not true either anymore. Usually you're going every 3 to 5 years. So there's a lot of times we just have to talk to people and find out what has happened in the past and try to kind of clarify what's the new recommendations, because they do change every 5 to 10 years. And so it is confusing, and patients don't have to know all of that because we can look it up and figure it out for you.
Excellent. Thanks, Dr. Tinguely, Dr. Buck.
Thank you.
And I urge listeners to, if you don't have primary care, get signed up. Call 970-731-3700. That's the main number here at the hospital. That's
right. You're correct.
Okay, good. And thank you guys so much for all you do, and we really appreciate the Pagosa Springs Medical Center right here. We don't have to drive very far. The clinic is open 5 days a week with great hours, and I've never had to wait too long. They're awesome. So anyway, thank you guys.
Thank you.
All right.
You got it.
See you later.
Let's hope the sun keeps shining all day today.
There you go, right? Have a great day, folks, and a great weekend. We'll see y'all later.